Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a great honor for me to introduce Danny Domingue. Is that how you say it?
Domingue.
Domingue, right. I'm sorry.
Everybody gets it wrong. It's like dough and mang. You just kind of combine those. It's French, but
I know you told me that before we started, and it's my stupid brain doesn't work around itself sometimes. Domingue.
Everybody in my little small town knows how to say my last name. And when I moved out to go to college, I just moved an hour away. I went to Baton Rouge at LSU, and not one professor could say my name right. And I was like, what's wrong with these people? I thought they were educated. And apparently, and then I went to New Orleans. Again, nobody could say my last name. Everybody wants to say, how you pronounced it. And when I moved to New York, everybody wants to pronounce it as Dominguez.
Yeah.
So
well, see, and maybe that's it.
All the time.
I had some friends that were, I had a couple of friends that were Dominguez. I had one in high school and one in college. And so every time I look at that, I think it's got to be Dominguez without the Z, but Domingue. That's all right. I like that. So tell my listeners where you're from, and then your journey through school, through dental school and all that, and then what you're doing now in your current private practice as far as days a week and what kind of clinic you work in.
Sure. So graduated high school in 1999, and I went straight into to college, and I really thought I wanted to go into med school. My grandfather was a physician, and he advised me to look into dentistry. So I went on a mission trip to Mexico with a bunch of senior dental students from the LSU School of Dentistry. And I got to, pull a couple teeth and then I started I enjoyed that aspect. I like to pull teeth. And so I started hanging around with my uncle, who's a dentist, Jerome Smith. And I just kind of liked all the intricacies of, the burrs and high speeds and all that. And I never really considered dentistry as a profession. So I started studying for it in my freshman year, graduated after 4 years, got accepted at LSU School of Dentistry. Went through my 4-year program, and the best advice my uncle ever gave me was, when you get out, you really don't know anything about dentistry. You know the basics, but you don't know how to run a practice. You don't, it takes 4 hours to prep for a crown, 4 hours for endo. You're going to starve if you come out of school like that. So he really advised me to do a general practice residency. So I applied to a couple programs, and I wound up getting accepted to Brookdale Hospital in Brooklyn, New York. And it was a 1-year GPR. I really just wanted to stay in a GPR program for 1 year and kind of get out of the state of Louisiana. So I got into the program. After I was there for a while, I really enjoyed it, and I was asked to apply to a they had two other fellowship programs. One was a dental anesthesiology program, and the other one was a dental implantology program. And both seemed really appealing to me, and I liked them both. The 1-year GPR, we did a lot of, it was real surgery focused, did a lot of Medicaid practice, and so I applied to the Implantology Fellowship Program, and it was a 2-year program. So I wound up staying on, and the instructor was Dr. Michael Katzup in Queens, New York. He would come 2 days a week. We would do surgeries, and then 2 days a week we would restore, and then 1 day a week we'd go to NYU and learn from Dr. Dennis Tarnow. And it was just all-day lecture from the history of literature to treatment planning to current literature, flap design, platelets, all that kind of stuff. And when I graduated, I had a couple of options to get into private practice. And let me talk a little bit about the program. It was an intense 3-year program. I'd work 80 hours a week. We placed around 200 something implants my first year as an implantology fellowship, and a little bit more than that. We did everything from hip grafts to chin grafts to ramus grafts to tibia grafts. It was a very extensive program, and I haven't done one hip since I've graduated, and I haven't done one chin since I graduated. But it's good to know all those techniques and know the benefits and do it in a residency program. So I'm a big fan of general practice residency programs and implantology fellowships. And Brookdale is not the only program out there. There's several other programs. There's one in Loma Linda. There's one in Tennessee. There's actually another one in New York. So anyway, graduated, wound up moving back to Louisiana to a really, really small town, practiced as an associate for about 2 years. And it was then when I kind of realized that I had enough speed and enough skill to start my own practice. So I really started looking to buy or start my own practice. And at that time, my uncle was 60 years old, and he said, why don't you come down and buy into my dental office and we can be partners? So I thought about it for a long time. I actually came over and I just worked for him for a year to see if we could, see if we meshed, and we eventually, it actually worked out pretty good. He's a really cool guy, real laid back, and we have very similar philosophies. We both enjoy implant dentistry. So been here for about 3 years now, and life's been great. I work about 5 days a week in this office. I usually get here around 7. I leave around 7 o'clock. I don't see patients. I usually start seeing patients at 7:30 and in around anywhere from 4:30 to 3 o'clock, depending on the day of the week. But I stay after work to work on my schedule, treatment plan, write referral letters, dictate notations and patient's charts. Just a lot of paperwork. I mean, anybody that owns a private practice, especially whenever you're getting started out, you got a lot of debt you got to pay down. And there's so many moving parts between management of your dental assistants, the front desk. Now I'm dealing with healthcare insurance, and it's just all these rotating things that you got to pay attention to whenever you're in private practice. So I stay here pretty late, but great practice. We got a referral-based practice. My uncle got into implant dentistry in like 1980s, and was every once in a while he'd get one case and to place some implants to support an overdenture, and eventually it just kind of built up because the periodontist and oral surgeon here in town weren't placing. So now we're fortunate enough to have a lot of referring dentists in our area that's sent to us to place the implants. He just places the implants on guys that are older and their patients, and the guys that are my generation that don't want to place implants to restore. I typically place their implants and help them with the restorative process, from single teeth to full arches. And so, but even in my time in the past, I've been in dentistry for 10 years now since I graduated school. And, even in this span of 10 years, implant dentistry, the technology is changed so much. So what I was doing 10 years ago has completely changed from what I'm doing now. And I think that's with anybody that's been in implant dentistry for the past 10 years. There's so much more technology that's evolving, the design of the implant to the cone beam technology to, guided surgery, the cost coming down so much. Even in, the original CT scan by iCat was purchased at a company here in Lafayette, bought it for $250,000. It was like 8 years ago. Now you can get a Vatec for like $80-something thousand. And I've seen the images, the image quality just second to none. It's tremendously impressive.
Yeah, I'm going to cut in right there. I actually just paid $67,000 for another Vatec.
Oh, wow. That's unbelievable. I mean, think about that cost.
It takes great quality. I've got an iCat in my other office, and it's just as good. So
the average dental, think about this. The average dental student, I just heard this statistic yesterday. The average dental student coming out of school is around $250,000 in debt. Can you imagine getting out of school and let's say you buy into $1 million practice, so your note's going to be, that's $600,000 to $700,000. And then, you get married, you're going to have to buy a house. Then you're going to have to spend another $250,000 for an iCat. I mean, the original iCat, that's a huge barrier for people, but the ability to pay for a $67,000 machine and to have so much more information is just, it blows my mind. It really does. I mean, that was back in the day, 20 years ago, one of the first Panorexes came out, they were $50,000. Now we're taking a CT on our patients for almost the same cost as a 3D-dimensional image. And that's what we do in our practice. We don't even charge, a lot of people in my area charge $250 for a CT scan, and I don't. I charge patients a Panorex fee because I get a second, 2D Panorex, and I don't want to push patients out the door and freak them out on the first consult visit. So we just take a CT scan, charge it as a Panorex, and then I get all this information. And oftentimes, and you'll see this if you're not seeing it already, the patient will come in for tooth number 10. That needs to be extracted in an implant. And then you start looking at the CT scan. It's like, wait a minute, you got internal resorption on number 3, number 14's blown out. it's asymptomatic, but it's got odontogenic sinus leaking into you need a root canal on that tooth. You need treatment planning, so much more dentistry, and avoiding those complications that patients are going to see later on down the road. And look, quite frankly, patients really appreciate it. They really do.
And you can show them that and say, see, this is going to be a problem. But I mean, I've seen dentistry going to 3D, and there's no way I'll ever go back. You're such a better clinician, even if you're not placing implants. But
look, when I was in dental school, the big thing was digital PAs. I remember getting out of dental school saying, I'm not going to take film x-rays. I'm going to get a digital sensor. Like, that was a big deal 10 years ago. I mean, now it's just, nobody's even talking about that. Everybody's talking about iCats and, CT scans. I keep saying iCat, but basically it's CBCT scans.
I've got an iCat too, and I just call them iCat, and I can't remember the name of that company, but yeah, no, it is. Now, that story sounds great. I graduated dental school in 2009, and I joined my father's practice and kind of jumped in and been learning implants the hard way, CE course to CE course. And I guess if I would have known about an implantology fellowship, I would have done that. But I guess at the time I thought you either need to be a general dentist or an oral surgeon, and there's no in between. So take someone through a pathway who's like myself, who loves implants, places implants, or maybe someone who wants to place implants through the credentialing process. I put it out on the line there that I'm going to get my Diplomate and the AAID over the next 5 years. Walk me through that process. And are you on any of the boards? I know you share some podcasts with the AAID. What process does that look like for someone like me, and what are some realistic processes that you would recommend?
Good question. So I was fortunate in the program that I did was the 2-year residency. I had enough hours of CE to apply for the associate fellow and the fellowship exam at the AID. And then I'd fly to Chicago, took the written test, and I took the oral test and passed. And then I was able to become a diplomate of the ABOI. So the ABOI is the governing body. It's like it's basically what it now is like the board certification to become an implant dentist. And that test is very, very difficult and very hard. So my route is going to be very different from everybody, because I did that 2-year fellowship program, and because I did the residency program, I went a little bit different route. So if you don't have that program, if you never did that program, there's several other different routes you can take. But essentially the route that most dentists take, well, let's talk about that. So the route most dentists take is they get out of school and they start practice because they want to pay down their debt, and they're ready to get their ready to start making money and get their fingers wet. And most people that we see entering the American Academy of Implant Dentistry come through a maxi course. So the maxi course has been around forever, and it is 10 weekends in 1 year, and it's around 300 hours of CE. And after that, you can take the exam and become an associate fellow of the AAID. Now, to become a fellow of the AAID, you have to start documenting cases. You have to have, let's just say 5 full arches of fixed within function for 5 years. You have to submit 50 cases of single tooth implants in heel ridges. You have to submit another 50 cases in sites that are going to be restored with an implant-supported overdenture, something along those lines. But the credentialing process is really hard, and those cases have to be in function for a minimum of 5 years. So there's a lot of documentation that takes place. And fortunately, since I was in the residency program, I was able to knock out all that in the first year to 2 years. And I just sat on those cases for 5 years until I was able to get enough documentation to submit them to sit for the Diplomate of the ABOI. So that's how most people come through the AID and join. And the AID is American Academy of Implant Dentistry, if nobody knows about that. But basically, it's the largest implant organization in the United States that has general dentists and specialists placing implants. They have an annual meeting once a year. I'm on the I'm the president of the membership committee. This will be my third year as a president. We always compare ourselves to other organizations like the AO and there's so many more organizations out there, and we're actually seeing the fastest growth of any organization out there, and with the highest retention rate of any of our membership, as opposed to other organizations. Every organization out there is great. The nice thing about the AAID is just recently, with this past October, the guy named Frank Recker, who's the attorney for the AAID, he sued the state of Texas. I don't know if you heard that, or he sued the state of Florida, and he also sued the state of California.
Yeah,
and won all 3 states.
I actually interviewed Frank right after that. So I had him on an earlier podcast.
He was on your podcast. Yeah.
Yeah. No, I think it's kind of amazing what they did down there, and like you're probably getting around to, they're turning implantology into a specialty, and the AAID is kind of the doorway into that.
Right. So the ADA recognized it, said, look, it's going to be a state-by-state issue. You guys figure that out. But we're going to have the American Board of Dental Specialties to recognize each of these as a specialty. So the AAID was the first one that applied and was registered with the American Board of Dental Specialties. So there's 3 states, and now Ohio should be the 4th state within a couple months. So you'll start seeing state by state dentists that are board certified from the ABOI will start being able to list themselves as a implant surgeon, a dental specialty implant surgeon, which is great for the population to be able to seek those dentists that have those qualifications. And again, you would have to become a fellow to ever sit for your diplomate exam. So it's a long process, and the credentialing process is difficult to get into and to sit for those tests. But it's one of the most gratifying certifications you can have. We always talk about. I'm on a podcast, the AID podcast, with a guy named Justin Moody, and we talk about that a lot when we interview dentists. Or a lot of dentists want to talk about their credentialing process, and everybody's really proud of it. There's Mike Picos, Carl Mish, Craig Mish, let's see, Lenny Linkow, and Hill Tatum. They're all diplomats of the ABOI, and these are all some of the best dentists that everybody knows. And it's a great organization. It's a lot of like-minded people that attend these events. It's just incredible. It's an incredible meeting, and a great group of guys. So I usually recommend people take the Maxi course, and I get a lot of questions. Should I take this weekend course? Should I take this weekend course? And it's like, well, that's good and all, but it'd be best if you took like a full immersion, and you got an appreciation, not just how to screw an implant in a bone, but the biology of the bone, the biology of the tissue, medications that affect implant osseointegration, and typically the Maxi course is best at that.
Yeah, I agree. I've interviewed Justin Moody previously, and I'm actually headed out to his. He's starting an implant pathway course, and
that's right.
I'm taking his first round of that and kind of dabbling with him this spring, and then I think I'm going to take the Las Vegas Maxi course starting this fall. And
with John Minichetti?
Yep.
He's the master.
So I think I'm going to take that. And so
he's an awesome guy.
At the end of both those, I should have my 500 hours.
Plenty of hours.
For the fellow.
Yeah.
And then I've got a bunch of cases I've got now, and so I'm documenting all those, and I'm going to look at the requirements and make sure I just get enough. So I guess at the end of all that, I'll take my written test, and then after that, it's just about case documentation.
Right. That's right.
Yeah,
That's right.
So,
and you got to be in function for a while.
And then you got to be in function, and then you got to sit on them, and then you got to, take more x-rays and photos after they're done. So, yeah.
Hey, it takes forever to get those cases and those photos.
I know it does.
I mean, it is unbelievable how much paperwork you got to fill out. And
it's always a paper trail.
Oh, absolutely. And the nice thing now, look,
papers.
You used to have to print all that out and submit it on a file. Can you imagine that? Now it's nice. You can just, now you got a little USB thumb drive, stick it all on there, organize it. You got to put, you can't put patient's names. So you just put like patient A, patient B, patient. Oh my God. It's a dream now. It's a whole lot easier. And it's easier for the AID to review your cases.
You're probably speaking from experience if you're the one doing the reviewing too. So you'll be probably seeing some of my sloppy work turned to here in the next couple of years. So
I'm on the board for the ABOI, the testing committee.
ABOI, yeah. Okay.
And I'm on the board, not for the oral, but for the written. And every year when we meet in Chicago, we every dentist that shows up, and I think it's usually like 10 of us that show up, everybody's got to bring 6 questions to the test bank. So that we have, and every year we've been doing this, and I've been on the board for 3 years now. So, I mean, we have a ton of questions. And the nice part about it is some tests have old questions. Every year there's new trends and technology that come out. So the questions are relevant. And we still have questions about subperiosteals and things like that. So it's good to know that. And there's a lot of pharmacology questions. There's a lot of bone physiology questions. It's a really good test. And it's not easy. It really is not easy, but it seems fair. And every year we always review the testing scores from the guys before that took it to see how they did and see which questions people had issues with and how can we reword those questions to make them easier. You know, if we have below a 50% pass rate on one question, sometimes we throw those out and then try to reword the question so it's fair for people to take.
It may not be a bad question, it may just be worded tricky.
Right, exactly.
Yeah. So getting away from all this testing and examination, I'm not sure if anybody other than me actually cares about that, but you know, I'm dedicated to that, and you'll be hearing from me probably along the pathway because I'm going to be chirping in your ear asking, hey, what do I do here? What do I do there? But so you practice 5 days a week doing dentistry, focus on implant dentistry. What courses are you currently teaching or attending yourself? I know you do some teaching, and you're probably a student all the time. So what are you teaching and what are you studying right now?
Well, when I first got out, I was lecturing once a month, and I would fly to Denver and lecture. I'd fly to regional meetings and lecture, and it was good, and that was all fine when I didn't have a kid. And then, you know, we finally had a child, and fortunately she's like the best thing that's ever happened to us, but I kind of had to back off the lecture thing. And then when I wound up moving to Lafayette and started this practice and I bought in, it was like, man, I really can't fly around right now. I really got to focus on building my practice and building my name in this community. So I'm really kind of just getting back into it this past year. And I started lecturing with Corey Glenn. He's doing, you know, he does like a 2-day guided course. And basically what I do is like a 1 full day of surgery, just implant placement, sinus lifts, soft tissue grafting, PRF, guided bone regeneration, titanium membranes, talk about different implant systems that I used in the past, results that I get with each one. And I used to be real, you know, in residency, I probably placed about 10 to 12 different implants. And that's, you know, maybe there was 15 implant systems at that time, 10 years ago. Now there's like 100 and something. It's unbelievable. So, and, you know, I was on a real big kick to place internal hex tapered implants for a long period of time because I like the thread design. I like the aggressiveness of them, and I really like the restorative components. But, right now I'm placing about 5 different systems because I really kind of think each system brings something else to the table. You know, I think Megagen has a really aggressive thread pattern on their wide diameter implants. It's really nice for maxillary bone in the posterior. I still like the Straumann tissue level implant for, mandibular implant supported overdentures. Love Blue Sky Bio, platform switched internal implants, very aggressive thread pattern. So I've kind of accumulated a lot of cases and try to lecture about which, not specifically which implant system that I'm placing and which one I'm advocating, because I don't get paid by any companies. But I just kind of talk about my successes and what I'm using. And I like to focus on what like cost efficiency. You know, I was spending $190 a vial for, half a cc from, company X. And over time, I found other companies that are less expensive and the bone product is just as good. We talk about bone carriers and, if you're going to use fusion or sticky bone and for different sites and things like that. So I really enjoyed it because I'm back in lecture. I'm back documenting a lot of my cases. I started posting a lot on Instagram. If any listeners are on Instagram, you can follow me. And then we teach a course in our office, a 2-day implant course that was originally started by my uncle. Let's see, it was started maybe 10 years ago. and it's called Implants in Black and White. It's just a 2-day course, and we have surgery in the morning, and in the afternoon, we just throw a bunch of lecture stuff out there. Basically, what I teach at with Corey as well. Corey came to our last one. We did a full guided, a couple full guided cases. Then I started a Facebook page with Implants in Black and White and kind of daily post some of our surgeries that we're doing in our office, Dr. Smith and I. So, and I really enjoy lecturing again. It's a lot of time to document all those cases, put PowerPoint presentations together, but I enjoy it. And so our next course is actually this week. It's going to be Friday and Saturday in Baton Rouge. And then you'll have to check out the website, blueskybio.academy, to figure out the next courses. I'm not really pushing my course, but whatever money that I get from my course or the Implants in Black and White, I donate to a medical mission trip in Mexico. So I don't make any money off of any of this kind of stuff. I take the senior dental students to Mexico, and we just do third world dentistry. It's the same mission trip that I went on, that I found my passion for taking out teeth when I was in college. So I take senior dental students down there now. We do fillings, extractions, endo. We got digital films there. And last year we took 12 dental students. It was 3 guys and 9 girls, and we had an unbelievable trip. It was phenomenal. We saw about 50 patients a day for 5 days in a row. That's a lot. That's a lot of patients for those guys, because they're used to doing, a filling. And one guy came up to me and he prepped a class too. He's like, "Can you come check my prep?" I said, "No, pack some amalgam. Let's roll, man. We got to go." I'm sure you did fine. Yeah. So lecture with Corey Glennow. I know you did a podcast with him. He's a great guy. He's doing so much with guided surgery. I'm really impressed. And he got me kind of on the bandwagon about a year ago. So I'm treatment planning a lot of patients with fully guided cases, everything from bone reductions and implant placements to single teeth to multiple teeth. There's a lot. There's so much. That area of implantology is growing fast. I mean, are you doing any guided cases right now? What are you doing in your practice? Are you freehanding everything?
No, actually, I do. I make a guide for every surgery that I do. I do a pilot guide for all my simple stuff. So what I'll do is make a pilot guide that gives me the perfect angulation and perfect, depth and the starting point.
I completely agree. That's exactly what I do.
And then I throw it away and then, take it from there. So it's like, it's a 2 millimeter twist drill to the length and depth of angle. And then I pitch it. I still flap it, and then that gets me started. I just pick up whatever kit you're using, X, Y, Z, and pick it up from there, because everybody starts you with a 2 millimeter twist anyway. And then, so that puts me in the perfect spot, because inevitably I would have messed it up somewhere, and so that takes that part out of there. And so then I'm widening and then, taking it from there and screwing in. And then on my bigger cases, on my implant overdentures or my tight cases or some upper anterior, I'll do fully guided on a lot of those. Obviously, if there's no teeth and you're putting in 4-6 implants on an upper maxilla or lower arch, I like to do guided, where I drop in the guide pins and put in 2 or 3 anchor pins, and then put in 4-6 implants that way. Just so that, because I've got it made with my lab ahead of time. You want perfect angulation for your restorative pieces on top, and whether it's zest anchors or fixed. If you do it freehand, you're going to have all these implants going different which ways, and restoratively it turns into a nightmare. So I don't feel like I necessarily need the hand holding, but I feel like it makes things better, and it makes the restorative in easier and more predictable. And so I plan everything ahead with my lab tech and make the guides that way. Smart.
And that's what I kind of advocate now is, why don't you just, if you have the technology in your office, why don't you just take the CT scan, work up the treatment plan, print it out in your office if you have a 3D printer. We have one. So basically I just print my own guides, and it costs me, a couple bucks to do it. And I don't charge the patients anything extra. And then all I do is just make my pilot drill, and I'll take an x-ray, double check everything. If I need to lay a flap, I'll lay a flap. I'm really kind of a flap guy. I like them because I'm really big into soft tissue augmentation around implants. And if you ever see some of my stuff, it's all about using PRF, or it's using soft tissue manipulation, or, I do a lot of, make a full arch incision, push the tissue back, put on a fixed prosthesis and let the tissue granulate in, or, manipulate the tissue by making a lingual incision, push on that tissue towards the facial if it's an anterior case, and just letting the palate granulate in and thicken up the tissue on the facial. I think it's a must if you're placing implants, or, every once in a while you can do an alloderm graft around implants, or even a soft tissue graft in the palate, which if the patient has a thin biotype and there's a lot of resorption on the buccal wall and you have some soft tissue recession, I think you have to. So, implants are one small thing of this huge realm of implantology, and anybody can screw a tooth in a bone, but it's dealing with complications. Like I saw a case today, the implant was placed, a custom abutment was torqued in. So this patient goes off to the general dentist to take the final impressions. Well, when he took the final impression, he accidentally got some impression material pushed into the sulcus. And then so that started a little inflammation and a gap in the tissue. And he didn't see that. So then he takes the crown, cements the crown on the abutment. Well, then the crown cement seeps into that sulcular depth. Well, the patient comes back a year later to our office, and there is a ton of bone loss. And, on a 2-dimensional X-ray, you can only see very little, and you can't really take a CT scan because there's going to be all this beam hardening from the crown and the abutment and the implant. So it's like, well, you can see a little bit on the 2D X-ray. Once you flap it, it's like, God dang, look at this impression material, cement. You got to clean it all up and, etch it and sandblast it and then rebone graft the site. So that's another facet of implantology, failures and how to fix them. And, prosthetic fail. I saw a failure today where this guy had a screw retain crown, and the full zirconia came out. The tie base was still left in the patient's mouth. And the restorative dentist was trying to take an impression of the tie base to make a new crown onto the tie base and cement it onto the tie base. Well, that's not going to work out. So and again, going back, I've never really advocated a weekend course to go and then start screwing implants in the bone. I think a maxi course is tremendous.
Yeah, it's, like you said, it's more than just putting the implants in the bone. I mean, if understanding soft tissue management is huge. I mean, soft tissue can make or break an implant. It's the same implant placed in the same bone, but the soft tissue around it can make or break it, either restoratively or aesthetically, can really make or break your case. So I think it's good that you focus on that, because and that's why I flap, and that's why I do a lot of things, said pushing the attached mucosa around, and you want to control the things that matter the most. And I think a lot of people underappreciate the soft tissue management side of implants. It's too easy to get stuck on, titanium and bone. But the soft tissue can make or break you. So you have a CBCT, you're using guides, you're using multiple implant systems. What exactly are you doing with bone grafting? I know that's a wide open question. Why don't you tell me about why don't you tell me about the bone grafting that you're doing in your office, and kind of tell me about your process that way, either whether it's just taking out a tooth and doing a simple extraction, graft, socket preservation, whether it's are you doing ridge splits and implant placement? Are you doing sinus lifts and those sorts of things also?
Yeah. So in practice, bone grafting, if we can't place the implant immediately that same day because there's too much infection or too much bone loss, we'll do grafting with either two products. We'll either draw PRF and or draw plasma, spin it out, get PRF, and make some sticky bone, place some sticky bone, and suture with PRF membranes. Or we'll use what's called fusion, which is we have a compounding pharmacist mix up this formulation of beta tricalcium phosphate with calcium sulfate and gentamicin, and we mix that with our bone product and place that in there. It's just a bone carrier, but it's very inexpensive, and it cuts down on how much bone you actually have to put in there, and it resorbs at a fair enough rate that angiogenesis can take in. into the site. You're not really overpacking the sites. I think it's imperative to learn how to do an internal sinus lift. One of the hardest things that I think is internal sinus lifts. And when I got out of residency, I was, even with my program, I was still kind of nervous because the visualization is so poor. And so I told myself, every single time I'm placing a maxillary posterior implant, doesn't matter if the patient needs it or not, I'm going to do an internal sinus lift and learn this technique and perfect it. So basically what I did, and now it's extremely easy to do an internal sinus lift. And external sinus lifts or lateral lifts are so predictable nowadays, especially with all these kits. I mean, I think I have like 10 kits for crestal lifts and lateral lifts, and I use them for various reasons depending on what implant I'm placing and what surgical site it is. So yeah, we're placing. I'm an advocate of smaller surgeries. So if I can do a little internal sinus lift with minimal amount of bone, say 2 to 3 millimeters, and can get an immediate implant placement, I'd prefer to do that for a patient as opposed to making a lateral wall, placing a bunch of implants, suturing it up, let it heal for 6 months, and come back and placing implants.
So are you doing ridge splits or anything with these Versailles burrs that are, reverse cutting and widening? I mean, do you know anything about that? And
I started using motorized osteotomes a long time ago when they first came out by BTI. I don't see how people practice without them. I think it's one of the best things in implant dentistry that's severely overlooked because of all the new trends. This new trend in osteodensification, well, that's really kind of been around forever with motorized osteotomes. It just wasn't, that phrase was never coined, and it's like a new trend. So yeah, I mean, we have the Densa drills. My uncle loves them, uses them all the time. I'm still a fan of the motorized osteotomes. They pretty much work in the same form and fashion. They just don't have this size as motorized osteotomes. Motorized osteotomes stopped at like a 4.5, and the osteodensification burrs go up to a higher level.
Yeah. So what are you doing with these motorized osteotomes?
It's essentially a drill, but it's a self-tapping, self-threading, engaging drill that's non-cutting. So you put your pilot drill in, and the next drill expands the bone. So if you have a site that's the cancellous bone is a poor trabecular pattern, and it's let's say it's D4 bone. Well, I just expand the bone and crush the bone and basically just osteodensification. And then you're able to, and a lot of times I'll just make my pilot drill and then just start using those motorized osteotomes until I expand the bone and just place my implant. And I don't use a final drill. That is my final drill. They're really, really nice for internal sinus lifts because they're not sharp at the tip. They're rounded, so you can fracture the inferior border of the sinus, tint the membrane up, add some PRF and some bone graft, and then suture everything up. Place your implant and suture everything up. I was listening to your podcast before this morning on the way to work, and Howard Ferran, man, he's a genius. He was just listing all these things about the Sanger, the guy coming from the United Kingdom and GMAC, and they want to give financing, and the way he talks is really funny. And what's really interesting, Howard has been so progressive, with starting Dental Town and, engaging members and getting people to take C and just kind of dumbing it down. Cause he's right. We're all talking about bonding agents and how many millipascals of strength is how long do you etch 20 seconds? And, and I'm gonna look at all these scientists and I know my bonding strength's better than theirs. And you're just a dentist and you're not even a scientist. And that's classic Howard. He is hysterical. He came to give a lecture I started at a local dental society in the town that I practice. It's called Acadiana Southern Society. And Howard came. It's called Acadiana Southern Society because the acronym is ASS. So all of our logos just say ASS on it, and our logo is a big molar tooth, and the tooth, the cusp look like butt cheeks, and the roots look like legs. It was like 4 of my good friends. We went to a local restaurant and had a couple cocktails, and that's the name, and it's kind of stuck. And, now we have like 40 members, guys my age, girls my age. And we just we bring people into Lafayette to give us lectures. In fact, next month, Ed Zuckerberg, who's the father of Mark Zuckerberg, CEO of Facebook, is coming to Lafayette, talk to us about social media marketing on Facebook. What's funny is the way we communicated is through email, not even Facebook. I was wondering if this guy was going to email me or Facebook messaged me the whole entire time, but we just communicated via email. But anyway, so I'm getting off track. So Howard, he came to give us a lecture, and it was a 9-hour lecture on a Friday. Not one person left. And by the end of the lecture, everybody was laughing the whole entire time. And one of my friends turned to me and he said, what did you get out of this? And I was like, I don't even know. All I know is like some guy in Zimbabwe charges $65 for a crown and I don't, and he's like talking about Spanky Dentist and making fun of people. And he's a comedian, man, but he really just, he dumbs down everything. And he's right. I love reading in Dental Town magazine. I always get it because I always love reading his articles. He's so smart. He thinks like, he doesn't think like a dentist. We want to talk about what bone particle do you use for your internal sinus lifts? Use a different one for sock grafting. It's like, God dang, everything works. Just use it. It's not that difficult. And people want to get tied down and argue which implant system's better than this implant system. They're all different. There's no implant system that's better than any other implant system. But I did disagree with one thing that he said on the podcast. And, he's talked about people going to, he's like, why don't people go to Spear and Coyce and spend all this money and they're never going to do a full mouth rehab case? It's like, well, why not? When I was in residency training, and everybody's like, well, it's so expensive, I'm never going to do it. It was like, well, God dang, I lived in New York City, one of the most expensive cities in the country, and with the highest tax rate. And I was a resident making no money. I had all the student loan debt, and I found a way to go to Coyce and take all of his courses and fly back and forth. In fact, his son, Dean Coyce, would fly from every week. Dean Coyce, who was a prosthodontist, would fly from Seattle he had a wife and 2 kids, and he would fly from Seattle to New York City, which is a ridiculously long flight and it's miserable. And we would take class together for 2 days, and then he would fly back and manage his private practice office for 3 days a week or 4 days a week. I mean, the guy was nonstop. And so I started taking Coyce course. This is before Dean and I became friends, but I flew out to Coyce and took one of his first treatment planning, and I was blown away. It's like, God, I didn't learn any of this in dental school. And it taught me so much about full mouth rehab and occlusion and, perio and restorative. And I think it's so important that every dentist that's a general dentist that gets out really should learn how to treatment plan properly. Because if you know how to treatment plan properly, then you'll know how to execute. Then you'll be able to have enough confidence to actually do the procedure. So, I think taking CE is so important, and I'm a firm believer, if you want to go to Spear, as long as you're doing some type of continuum like that. So, so the only thing I disagree with what he said is, I think it's important that dentists go to these CE courses and learn how to do full mouth rehab, learn how to do bite reconstruction. Because I think every dentist should be doing full mouth reconstruction. A prosthodontist can do it, and Coyce isn't, but it's very similar to a prosthodontic residency. In fact, some of the smartest guys that I know are prosthodontists, and a lot of my friends that were in the residency program with me were prosthodontists, and I actually thought about becoming a prosthodontist after school. Because man, those guys know occlusion and bite and excursions like nobody else. And I have a high respect for that's probably one of my favorite professions. If I wouldn't be a general dentist, I'd be a surgical prosthodontist. And I'm not even sure where I started with that whole thing. I kind of got on a huge tangent.
I think you're just getting at, there's a lot of information out there, and just don't stop your learning curve. I mean, don't look at something and say, well, why should I take that? Maybe look at something and say, well, why shouldn't I take that course? Why not expose myself to this? Because even if I don't do it, at least I'm aware that it's out there and somebody's doing it. And maybe you just realize, hey, I know this prosthodontist guy down the street, and I feel good diagnosing this, but maybe I don't feel comfortable doing it. That you increase cross referrals. I mean, maybe you learn about a procedure you didn't know about, and you find a love or a passion for it that you didn't know you had. And I think that definitely happened with me with implants. I thought I wanted to do a bunch of cosmetics, and I started learning more about implants and took more courses with that and realized, that's where my passion really lies. And if you'd asked me, my first year or two out of school, I don't know that I would have told you that. So I took these courses that expanded my thinking, expanded my knowledge base. Then I found something I really loved, and now I drift further towards that. But don't close your eyes to what else is going on around you.
Exactly. And my big thing is I love implant dentistry, and along the same lines of what you were saying, I took Invisalign course because the guy that I was practicing with in New York, I would moonlight on the weekends. I would work from like 6 a.m. to 10 p.m. on Tuesdays and Thursdays. And if I was on call, I'd just stay at the hospital all night because it was in-house on call. But so I'd moonlight on the weekends to try to help pay for my COIS course or anything that I was doing extra. And this guy was a big Invisalign, so I took an Invisalign course and I did some Invisalign cases. And I was like, I like it, but I don't have enough control. Let me take a 6-month smile course. So I took a 6-month smile course and I did a couple of those. It's like, you know what? I can appreciate it. And now I've learned a lot about ortho, and I know I don't want to do it. So I know I'm going to refer those cases. But now, which is great for the orthodontists that are here in town, I did all that extra CE. Now I'm referring a lot to those guys, and because I can see what they know. And so if you don't like implants, you don't know until you take a couple courses, figure out if you like it, try to place a couple implants. If you don't like it, then you're going to be a better referral source to your oral surgeon, your periodontist, or a general dentist like me that places implants. So yeah, I'm a huge fan of any type of CE, and that's what's so good about the AAID. Once a year we have an annual conference, and you have all these like-minded dentists that are revolutionary. I mean, these guys are so impressive. Some own multiple offices, some are killing it. They're just doing, I know one guy, that places 800 implants a year. I mean, can you imagine placing 800 implants a year? I don't even know how you have time to work up those cases and place that many implants, but 800 implants a year. And this guy goes to a regular meeting. He kind of just tells you a success story and how he started out and how he placed so many implants. And he didn't even advertise. He does not spend any money. There's no radio commercial. There's no TV commercial. There's nothing. He didn't send out mail outs or anything. It's just been word of mouth referrals, which is really the best thing I think in the world to build your practice, word of mouth.
Yeah, no, I think I'm out of town between now and the end of April. I think every other weekend for CE. So my wife's going to kill me because I'm going to.
Good for you.
I'm going here, I'm going there, I'm going to Vegas, I'm going to California, I'm going to.
Well, do it while you're young. Do it while you're young. And
I wish I was as young as I looked. Unfortunately,
you do look young.
I do. I'm 35 and I've got 2 kids, and I feel like an old man. But I hate leaving my kids and wife. But I know I've got to do it, and I love what I do, and I love that passion. And I'll definitely.
And that's why I think this podcast is so cool, man. Because there's a lot of dental podcasts out there, but nobody's really addressing the subject so specifically as dental implants, as this seminar. So everybody that you're interviewing, all they're talking about is dental implants. And so what's nice about it is everybody that's listening to this podcast, you're going to have so many different viewpoints of how people got in implant dentistry and their success stories. And so then, you can figure out if I'm in New York City, that's going to be a whole lot different from this guy, Danny Domingue, who's in a small town of 150,000 people. I really like this podcast for that exact reason. Because implant dentistry is one of the hottest topics. And it wasn't like that 10 years ago when I was getting out of school. Now everybody that getting out of school, all they want to do is, I want to place implants. I want to place implants. I want to buy a CT scan, which is totally changed. And I guess it's because groundbreaking technology, the cost of entry is going down so much, like we said earlier, and guided surgery. I mean, guided surgery is so inexpensive nowadays. And if you're not, if you're paying $800 for a guide or $500 for a guide, I'd recommend all these listeners to download Blue Sky, buy a plan, start learning the software, and start making your own guides. The export fee is only $15. You can print it on a Robox printer that I have, like one I have. That Robox printer cost me $1,500, and I can print out a guide for less than $5. And if say a patient comes in, the nice part about it, Phil, is if I see a patient on Wednesday and they want to schedule for a surgery tomorrow, it's like, all right, we'll take a CT scan, take an impression. I'll go ahead and work it up tonight, print it out. It'll print all night. And when I get back to work tomorrow, the guy will be sitting on my desk ready to rock and roll. That's incredible. That really is incredible.
Yeah, that's a game changer, the time frame, man. I've got a good lab that I use, and it's a fair price, and I don't have a problem with that. But the same day or next day is a game changer, and so I'm not in that make your own guide group. I'm definitely got one eye on it. You know, I know what they're doing. I watch from a distance and see what they're up to. I don't do that yet, but I can see myself doing that. I'm kind of waiting for them to get all that technology worked out, and I'll just scoop it up at the end when it's ready to rock and all that, because I do love that concept of, yeah, let me take your scan, let me take your impression, I'll numb you up, make your guide, and we'll get this thing going. I mean, I don't think it's going to be that unreasonable for that to be the case in a couple of years. Oh,
no, absolutely. Look, in this guide, I mean, this printer is, the 3D printer that I have is the same size as my HP Office Jet Pro sitting right next to it.
Exactly.
It's not a huge footprint, you know. I didn't have to measure a size of my office and cut out anything in my wall to get a 3D printer in my office. Just sitting on my desk right next to my printer, which is just incredible. Just incredible. For $1,500, we just bought it from the UK.
Which is just a tiny bit cheaper than the one Cerac will sell you.
Just a couple bucks.
Just a couple dollars cheaper. So
I love how they sell it to you. It's like, well, how much is that? Every month you can pay $500. So, well, that's not what I asked.
You only have to produce 10 crowns a month for this to pay for itself.
Right.
What about
it's a sales pitch.
What about the 20 crowns I got to do just to pay my bills and feed my family? So,
and that's exactly what Howard was saying in your podcast. You know, not everybody has $10,000 for an implant. You know, not everybody has $60,000 from full mouth reconstruction. So, you know, our office helps people afford their treatments by financing all that work. And I mean, if I didn't have that, if I didn't place implants on people that smoked or people that dipped, I wouldn't be doing as many implants as I'm doing nowadays. You just have to be able to manage complications and be able to help people out and work with them, give them treatment option A, B, and C, and advise them. You know, and that's usually what I do when I come for a consultation visit. You know, if it's a really in-depth case, they'll come in. I'll, you know, give my whole spiel, show them I'll take a bunch of photos. They come back in for a treatment presentation, you know, a couple of days later, and I'll have this long PowerPoint presentation. This is your teeth. These are the areas of teeth that you're having issues with. This is a diagram of how many teeth you should have, how many teeth you actually have. This is where the implants would go in these sites. This is a 3D video of your jaw and where the implants would go. This is how we can restore you. And then I got this new software by Dentron Imaging, and it is impressive. Forever, what I would do, you know, I'm very visual, and I think most guys are, and you can talk to me blue in the face, but if I can see a picture of the before and after and have an idea of where I'm headed, it makes sense to me, right? So my wife, whenever we were, you know, renovating our house, she's like, you know, what do you think you want for the cat? I was like, I don't know. What does it look like? Show me a picture of it. And when she showed me, I was like, all right, I like that. Yeah, that's what I wanted. Let's buy that. You know, so I started when I did that, I was like, well, why can't I just do that with teeth? So I got Photoshop on eBay for like $50, a Photoshop 7.0, got it, and I started Photoshopping teeth in people's mouths. And man, I can't tell you, Phil, how many patients didn't even ask a question. It was like, I mean, who cares what it costs? I want to do this. But that Photoshop took me 15 to 20 minutes to sometimes 30 minutes to get it perfect. And that's a lot of time. That's a lot of time eaten up. And sometimes it wouldn't look that great, or it's difficult. And I can't tell you how many hours it took me to learn the software, because it's a very cumbersome, very intelligent software. But anyway, so going back to what I was saying, Dentron Imaging came out with this new software, and it's like a Smile Design Studio. And I'm telling you, within less than 4 minutes, I can print out a before and after of somebody's teeth, of what they look like. And I can't tell how many patients that have signed up for the whole case and not even asked a question about how much it's going to cost. So all those little things that you can do to help people understand treatment is very helpful, especially when you're presenting, you know, big treatment plans like $60,000. And you know, I used to be a big advocate of let's just dive right in, you know, get the patient in for one consultation visit, and I don't want to waste their time. But it's really nice to step back a little bit and spend some time treatment planning in my office after hours and figure out where's the best location for these implants. Is this tooth even if I do a root canal and build up crown, is going to last them for 5 to 10 years, or is it best to take it out and just, include that tooth in the bridge? And then give them option A, B, and C. Option A, this is the best thing you can do for yourself. Option B, this is what I recommend for the price. It's probably your best recommendation. And option C, this is the cheapest thing you can do. I'm not an advocate for it, but that's your third option. And honestly, patients that can only afford option C, and I really want to give them option B, then I do anything that I can to cut my cost, to lower my overhead expense so that they get option B. And if it's giving them 10, 15% off the overall cost, well, I don't take insurance. So I kind of see that as like a wash. And if they want to pay cash, well, then I'll give them 15% off, if they don't use care credit or things like that. I really try to work patients to give them the best treatment possible. Or if they're really in a bind, they want option B and they just cannot afford it. Well, then look, let's just do option C and reevaluate you in a year or two, and maybe we can upgrade you to option B. Say we just do 2 implants this year and implant supported overdenture, and maybe wait a year or two till your insurance kicks in, your finances come around a little bit. We'll place a couple more implants. Next year, get on 4 implants, maybe place 2 more the year after that, and then eventually get you into fixed.
Yeah, I like that, and that's I do a lot of that in my office too. It's hey, I can put 6 in there and do some screw in, zirconia or PFM up there, and it'd be perfect. Or I can do 4 overdentures, 4 implants and an overdenture, which is option B. Or I can do option C, which is take out the bad teeth, put in bone, put in some crummy partial for a year or 2, put in implants later. I'm always working them back up to option B, saying, okay, we're going to take these teeth out. We're going to put in a transitional partial. We're going to put bone graft in, because when insurance kicks in next year, we're going to put in implants. Or, always work them back up to option B, give them financing, give them hope. And, like you said, those pictures or before and after pictures, models in your office, anything you can do to get them to see and feel and hold that final product. And then people find a way to come up with the money. And it's like, okay, we can do complete dentures for a couple grand, which we're just not going to do. We can do, 4 implants and an overdenture for 10 grand. And then 20 grand we can do, screw down. And I'm just, throwing out random numbers, but it's always like, okay, let's, give them 3 options, give them 2 or 3 years to do it. Don't tell them this has to all be done at once, has to be done tomorrow. Give them some options, make them feel good about where they're at, make them feel good about where they're heading. And then always kind of be nudging them to that middle ground that is going to be best for them. Right.
I agree.
Yeah.
So, man, this is the best podcast I've ever done. Thank you so much for having me on your show. This was amazing, Phil.
I'm excited to have you. So let me leave with 2 things. One, I'd love to have you back in a couple months, because I think there's so much we didn't even get to that I think listeners would love to benefit hearing from you. And then 2, myself included, if people want to get a hold of you or come to your course, I'm definitely going to come to one of your courses now that I know about it. How do they come to your course, and what's the best time to come? I'm swamped this spring. Do you guys offer any in the summer or fall, or what do you do course-wise?
We do. We're actually this weekend we're back to launch our next couple of courses coming up. So I think the best way to get in touch with me would be if you're on Facebook, look up Implants in Black and White, and then request to join that private group. You'll be able to see some of the cases that I post daily. If you're on Instagram, look me up. I think I'm Danny.Domingue, or you can look me up at Implant Diplomate. That's my name on that. Or shoot me an email. I mean, that's the easiest way to get in touch with me is domingue.danny@gmail.com. Our next course in my office is going to be in April.
Where does somebody find your courses? That's not on your main website for your patients, is it? Or do you have a different one?
Yeah, we have a different website for that. Yeah, right now we're the course at our office is going to be April 7th and 8th, and it's going to be a full guided. We'll go over guides on how to make them, how to work them up. We'll do several guided searches. What we'll do is we have 5 or 6 patients in the morning, and we'll place 10 to 20 implants each day. And what we do is we have a lot of patients, which is really neat. We have a lot of patients that can't afford implants. Keep those patients and use them for our course. And so we give them we basically do the case for almost free, or give them just a huge discount so they can actually get the work done. And we do those for the courses. And so basically whenever the doctors come to pay for the course, all that money we get to donate to Mexico. So Dr. Smith and I just basically just volunteer our time. And, because implant dentistry is dentistry itself is just a passion, everything. I love everything about it. This is one of the greatest professions. USA Jobs just voted, or USA News just voted the #1 job in the United States as a general dentist. Isn't that amazing? And we're on the top 10. There's like oral surgery and ortho, and I think PAs were on there. I mean, that's incredible, right? We're the #1 job.
I mean, with all the crap we gripe about, we still got it better than most. And,
Absolutely.
Our hard days in the office still beat a lot of people's hard days out digging ditches and dying on the construction side, or some other fighting off the
and we get to own our own business, which is a good thing and a bad thing.
Yeah, it is a good thing and a bad thing. That's why we're here till 7 o'clock every night. But
right, exactly.
It still gives you that flexibility. So it's great that you're giving those discounted prices to the people in your courses. That's fantastic. So if I want to sign up for your courses, I go to blackandwhiteimplants.com.
Yeah. So it's actually one of the courses recognized by the AAID as a recommended course. And what you need to do is blackwhiteimplants.weebly.com. And you can go on the site. You can learn a little bit more about the 2-day live surgery course, learn a little bit about me and Dr. Smith. You can email me through this website. There's some surgical videos on there, some cases, and then there's some literature at the end. Eventually, we'll have a way to register online, but right now, you're just going to email to submit for registration.
Great. So if that's a registered course, does that mean that counts towards my AAID hours that I need to get? Okay,
it
good. It
absolutely does. Yeah.
Good. I would expect that from you. So, Dr. Domingue, I appreciate your time today. It's been great having you. I'd love to have you back on in a couple months when we get
Let's do it.
More to talk about, and
keep pumping out these podcasts, man. I'm listening to you.
I will. I'll pump them out, and I'm gonna look you up, come down and take a course of yours, and I'll be hitting you up for some questions as I try to go through my application process with AAID.
Cool, man. Look forward to it. Good luck.
Thanks for your time this evening, and have a great night.
You too. Bye-bye.
Bye.